lasting several months. Botulinum toxin has also been used to manage spasticity. Levodopa is an option for children with athetoid CP. A new type of drug treatment showing promise in children with moderate to severe spasticity is the surgical implantation of a pump under the skin for continuous delivery of the antispasmodic drug baclofen. There are also several assistive devices helpful for children who have CP, such as walkers, positioning devices to allow a child with abnormal posture to sit or stand correctly, customized wheelchairs, and especially adapted scooters and tricycles. Your nursing care for the child who has CP must be highly individualized, related to the type of disorder and level of severity. Major issues are skin integrity. It is important to assess for redness or other evidence of pressure areas. Also keep the skin clean and dry and reposition the child frequently. Prevention of contractures or deformity through the use of splints or braces, frequent changes of position, and passive range of motion and stretching exercises. Assistive equipment such as braces or walkers should be checked frequently for correct alignment and the presence and correct functioning of all parts. Wheelchairs and crutches should be adapted to fit the individual child. Postoperative care includes extensive rehabilitation as well as immediate care related to post-op complications such as bleeding, infection, DVT, and atelectasis. Feeding difficulties include poor suck and swallow, hyperactive gag reflex, and vomiting. It is important to use adaptive devices as indicated and make sure the child is positioned properly with adequate support of the head and neck. It is important to encourage the child to be as independent as possible, using adaptive devices to facilitate self-care. Also remember that parents are typically the experts in issues related to the care of the child and should be a central part of the multidisciplinary team. For example, the parents will be an important source of information about what types of play the child enjoys. Play, both alone and with other children, must be encouraged as it is an important part of the life of any child. So is rest. Daily activities require the expenditure of a great deal of energy, yet the child with CP finds it difficult to rest and relax. You'd provide an environment that facilitates rest, limits overstimulation, and allows the child plenty of time to accomplish ADLs. Also, in collaboration with the healthcare team, you'd provide the family referrals to community and national resources that will support them and their child in coping with CP. Next is an overview of head injury, followed by your nursing role in caring for a child who has a head injury. Head injuries involve the scalp, skull, meninges, or brain, and result from blunt trauma, shearing forces, or penetrating injuries. The major causes of brain damage or injury in childhood are falls, bicycle injuries, motor vehicle accidents, sport injuries, and gunshot wounds. You might hear the terms coup, contra coup, shearing, and maximum shearing in association with head injury. The physical forces of acceleration and deceleration cause deformation of the skull and mass movement of the brain. This deformation can cause bruising directly at point of impact, that would be coup, or indirectly at a distance as the brain strikes the skull away from the point of impact, that's contra coup. Shearing forces are caused by unequal movement or differing rates of acceleration at various points in the brain. Maximum shearing forces are on the cerebral surface, but the most serious effects are often in the brainstem. The most common head injury is a concussion, a transient or prolonged reversible alteration of consciousness, which may be followed by amnesia, vertigo, nausea, and weak pulse. Breathing can be unusually rapid or slow. When consciousness returns, the child is likely to have a severe headache and possibly blurred vision. Post-traumatic amnesia is characteristic of a concussion and consists of two parts: retrograde amnesia, the period of time before impact, and anterograde amnesia, memory loss after injury. Memory of both of these periods generally returns over time, although there may be some permanent amnesia. It's important to remember that loss of consciousness is not necessarily a hallmark of concussion, especially in children. Confusion and amnesia are more accurately defined concussion. Contusions are petechial hemorrhages along superficial areas of the brain at the point of impact, again coup, or at a distance, contra coup. The areas of the brain most susceptible to contusions or lacerations are the frontal, occipital, and temporal lobes. Signs of contusion vary from a mild, brief extremity weakness to unconsciousness and paralysis, and can be difficult to distinguish from a concussion. Although cerebral lacerations are usually associated with penetrating or depressed skull fractures, they may occur without fracture in small children. We'll discuss that in a few minutes when we review shaken baby syndrome. Bleeding in and around a tear in brain tissue causes longer and more severe unconsciousness and paralysis, resulting in permanent scarring and some degree of residual disability. Head injuries also include fractures. They can be linear, usually from a low-velocity impact. This type accounts for the majority of childhood fractures, but they are uncommon before the age of 2 to 3 years. They are often asymptomatic and heal in 3 to 4 months without special treatment, unless there is involvement of a blood vessel, a cranial nerve, a paranasal sinus, or the brainstem. Your client might also have a depressed fracture, with the bone broken locally into irregular fragments that are pushed inward, causing pressure on the brain. This requires surgery to elevate the fragments. It is also uncommon before the age of 2 to 3 years, as the softer infant skull indents instead of breaking, creating a ping-pong ball-like depression. Or it might be a compound fracture, where tissue laceration extends to the site of the skull fracture. This requires surgical debridement, reduction of the fracture, and antibiotic therapy. A basilar fracture involves the basilar area of the frontal, sphenoid, ethmoid, temporal, or occipital bones. Signs and symptoms include bleeding or leaking of CSF into the nose, nasopharynx, or middle ear, a positive battle sign, that's discoloration behind the ear, and raccoon eyes, or evidence of hemorrhage around the eyes. And finally, there are diastatic fractures or traumatic separations of cranial sutures. The lambdoid suture is most often affected. This is rarely seen after age 4 and usually requires no treatment. Cerebral complications due to skull fracture include hemorrhage, infection, edema, and herniation through the tentorium, which is the dura mater supporting the occipital lobes and covering the cerebellum. With hemorrhage, epidural or extradural blood, usually arterial, rapidly accumulates between the dura and the skull, creating a hematoma. Signs and symptoms vary with the location and severity of the injury. They include loss of consciousness, dilatation and fixation of the pupil on the affected side, weakness or paralysis, and increased deep tendon reflexes on the opposite side of the injury, decerebrate posture, and abnormal respirations. Children can have nonspecific symptoms like headache, vomiting, and irritability for 48 hours or so after the injury. Clinically significant epidural hematomas are rare in children younger than 4 years due to the increased resilience of the skull, escape of blood through the fontanelles, and a lower systolic blood pressure. There can be subdural bleeding, usually venous, between the dura and the cerebrum. This is more common than epidural hematomas and is seen most often in infancy due to birth trauma, falls, assaults, or violent shaking. It can be acute, associated with contusions or lacerations, and developing within minutes or hours of the injury. Signs and symptoms include increased head circumference, bulging fontanelles, retinal hemorrhage, hemiparesis, quadriplegia, altered level of consciousness, and unsteady gait. It can also be chronic, common in children with open fontanelles and sutures. Signs and symptoms vary with the brain damage sustained and the age of the child. They include seizures, vomiting, drowsiness, increased head circumference, irritability, personality changes, headache, developmental delay, and failure to thrive. There can also be subarachnoid and intercerebral hemorrhage. Signs and symptoms include seizures, nuchal rigidity, and altered level of consciousness, depending on the amount and location of bleeding. Another complication is cerebral edema, which always develops to some degree after head trauma and usually